Hello, welcome to ecancertv. I'm Prof Fizazi from Gustave Roussy in Ville, France, and we're all here at the ASCO GU meeting in Orlando, Florida. I'm happy to be here with a panelist. This is Dr. Santis from Vienna, Dr. Dr Rubin from the US at Cornell, and Dr. Prof Miller from Germany in Berlin Charité. So we've had a very nice day here at ASCO GU, specifically focusing on prostate cancer with lots of interesting news, and we're going to be very happy to discuss that with you today. So first of all, maybe Mark, we started with a discussion about the 4K score, which is a kind of biomarker that is trying to find its place for patients who are potentially candidates for biopsy. What do you think about the data that were presented today?
Yeah, so today's presentation I think was quite exciting. The biomarkers developed on very large cohorts in Europe and now in the United States where it was validated. And it's based on a PSA type panel of biomarkers, so kallikrein biomarker panel. And the idea is that it would identify individuals who do not need a biopsy and perhaps can wait for a while until things change and then they would need a biopsy. So I think that's quite exciting. The background data, the actual development and the validation make it, I think, a robust biomarker. And I think the focus of today's discussion on biomarkers was how do we then take these biomarkers and move them into clinical applications. So that's the next step that we have to see what happens.
Okay, thank you. Kurt, as a urologist, do you believe this is a strong data enough for patients with elevated PSA who are maybe candidate for a biopsy?
Well, it's at the end it's about risk stratification to see can you avoid biopsies, as Mark said, in a number of patients. What they didn't take into account though is the use of MRI. And this probably, and at least in Germany and Europe, there is a real tsunami coming with the MRI. Even in first-line decisions, should patients undergo biopsy or not. So, and this gives you, of course, an additional risk assessment in terms of is there a risk for aggressive prostate cancer or not. And so I'm not sure how that will really play out. You have additional markers, and then you have imaging. And this is totally new for prostate cancer. Right. And currently, we tend to probably overuse MRI. So most of our patients undergo MRI before they go to a biopsy, and then they undergo fusion biopsy, not traditional randomized biopsy. So we will see how that really, will be teased out. Is there a better role for markers, or is it imaging, or is it both, to really reduce the number of unnecessary biopsies? And so I think it's good, but it's not already in the MRI era. And I think this is going to be in the next 5 years. That's a game changer.
Okay, very nice. Staying with you, Kurt. So let's say that our patient has indeed prostate cancer. We've heard today 3 randomized trials looking at patients with intermediate prognosis localized disease, 2 from Canada, 1 from the US, and those were trials testing various forms of radiation therapy, plus or minus ADT, plus or minus brachytherapy. And it seems that in all these trials, it seems to be better to use maybe short-term ADT on top of radiation and maybe brachytherapy really to boost the dose of radiation. But this was for relapse mostly. We don't really have data on overall survival. Can you give us a more general, image picture about intermediate disease? Because it's always challenging to make a decision.
Yes, it's as you said, and if you look at in the guidelines, it says, well, patients may need ADT plus radiation, but it's not clear. We don't have solid data like we have in high-risk disease. So currently, we would tend to have these patients on short-term ADT, like you just said, and it seems to convey an advantage. However, what we've seen also, even after longer follow-up with the aggressive tumors, that progression-free survival does not necessarily translate into overall survival advantages. And we've seen this with other trials, like with the adjuvant radiation trials and with the salvage radiation trials. So we need to get, and this is always easy said, difficult done, takes a long time, but we need to get longer follow-up before we really see, is that the way to go?
Okay, thank you. Now, a very hot topic at the moment for, let's say, a year or so, is whether we should treat with docetaxel all the patients with de novo, mostly metastatic disease. We now have 2 trials available, Chartered and JTUC-15, that not necessarily show exactly the same results, at least in terms of overall survival. So Maria, what do you think? What is now your practice? What is your recommendation for your patients?
Well, we are currently in a quite difficult situation because we have contradictory results in 2 very similar trials. The Charted data was presented at the at the ASCO meeting in 2014, and today we heard an update of the JTUC-15 trial. So the Charted data brought in positive results in favor of giving immediate docetaxel in hormone-sensitive disease together with androgen deprivation therapy. And the difference was really huge. It was in the high-volume disease patient population, a 17 months difference for overall survival. So this is a remarkable result, of course. So on the other hand, the JTUC-15 trial was a negative trial concerning overall survival in the whole population. But there were also differences between the trials. So there was a difference in the final results for overall survival, but difference in the patient populations that were included. So in the JTUC-15 trial, fewer patients with high volume disease were included. This might be a major and important difference, which might make the overall survival difference sort of smaller. In addition, the JTUC-15 trial included fewer patients. This was a smaller trial, so it might not have the power to show the overall survival difference. So there were different issues. Today, however, we saw a very interesting analysis of the JTUC-15 data, because what the investigators did was to adjust the high volume definition in the JTUC-15 trial that was primarily different from the Charted trial. And they tried to look at the patient population with the same high volume disease definition as in the Charted trial. And actually the results came a little bit closer to what we saw in the Charted data with the new definition. However, the results were still negative. So we are now in the situation sort of as before, although we have a little bit more evidence towards primary use of docetaxel. However, I think we need a 3rd trial, and we actually expect that data from the Stampede trial that might be presented at this year's ASCO meeting. So we are very much looking forward to a 3rd trial that might weigh the balance and help us in deciding which will be actually the new standard of care for hormone-sensitive disease in patients with high-volume disease.
Right. Kurt, what is your current practice for your patients with de novo metastatic disease? Do you recommend routinely docetaxel? Do you discuss that with your patient?
I think about Eric Small came to the same conclusion. He was the discussant of the JTUC trial, and I think interesting for me is in the whole population there was still a 13 months difference in the JTUC trial in terms of overall survival, but it was not significant. So a trend is here, and in a patient that really fits the definition, like he's young, he has high volume disease, he has visceral mets or peripheral metastasis of the bone, I would certainly recommend to put him on 6 cycles of docetaxel. Okay. So I think, you know, the upside looks much better than the downside of that decision. So that's why I would recommend it. I mean, there's still some question marks, as Maria said, but, you know, deciding in daily practice, I would decide.
We shouldn't wait that long.
Right, I mean,
data are maturing. Mark, you know, staying with the taxane questions, we had last year, you know, quite very impressive news about the AR-V7 variants being linked with efficacy of either abiraterone or enzalutamide. And today we presented data with the same biomarkers regarding the efficacy of taxanes. What do you think about this data?
Well, I think a lot of the data we're seeing now obviously needs to be replicated in other studies, and we heard there are going to be prospective studies looking at it. It gets back to biomarkers, so the actual way that the splice variants are being measured will need to be looked at carefully. So I think I feel the jury is still out on how useful this will be. The initial publications have been really spectacular, and now we just need to see it validated in other settings. So it could potentially be a useful biomarker. I would note that the TCGA, so the US version of the ICGC, or Cancer Consortium, is going to be reporting on normal prostates and tissue as well as cancer. And we do see the splice variant coming up in about 50% or greater of untreated prostate cancer. So there is interesting possibility that this is an early marker, or that it's a very commonly expressed biomarker. And I think a lot more has to be done to understand the meaning in regards to response. So.
Okay. Maria, staying with the question of abiraterone and taxanes. For a while there was some debate as to whether taxane might be still active for patients pretreated with abiraterone. We've just had some new data coming from the CU302 trial analysis about taxane efficacy post-abiraterone. Can you summarize that for us?
Sure. Well, I think that sequencing question is a very important question for our daily clinical practice. Everyone, of course, asks which drug to use first, and if to go for the newer AR-targeted treatments first and chemotherapy later on, or the other way around. We have more data for the other way around, of course, from our prospective trials. So the Cougar 301 trial or the AFFIRM trial. The other way around, in patients who were pre-treated with abiraterone and enzalutamide, we have fewer data. So at this meeting, we saw a post-hoc analysis of the Cougar 302 trial in patients who were pre-treated with abiraterone and had subsequent docetaxel. And it was good to see that those patients had a nearly 50% PSA response, which reassures us to use chemotherapy also in the post-abiraterone setting, of course, and this helps us in decision making. So I think we, right now, even with the lack of prospective randomized trials for sequencing, we should not be afraid of using abiraterone or enzalutamide in the first place, and then sequencing with cabozantinib or docetaxel, so using taxanes later on.
All right. Staying with abiraterone, Kurt, abiraterone requires co-prescription of a steroid. So what do you think about the long-term exposure to steroids for these patients?
Yeah, we had a paper here looking at like 2,000 patient years of Abi plus prednisone, and from the Cougar 301 and Cougar 302 trial. And I would say, as expected, there was no real problem in terms of long-term side effects of prednisone in that setting. So, I mean, there's still some debate what exactly does prednisone or corticosteroids in association with Abi, or, you know, we had that discussion when they teased out the corticosteroid patients in the AFFIRM trial, I think it was, and they did much worse than the patients without. But for me, I mean, prednisone for me is like an active drug in prostate cancer. And so I don't think in association, given an association with abiraterone, that there is any disadvantage of the patient. So side effects were few. And so I think that's the wrong debate when you think what to do first. You know, there's always now the enza-abi question, and the prednisone is not the argument pro and con. That's my conclusion from that. I mean, unless you have a patient with a diabetes or something where it's a different story. But by and large, I don't think that answers the question what you should use first.
So we've talked about active drugs, we've demonstrated impact on overall survival, taxanes, abiraterone, etc. And today we've heard for the first time the results of a phase 3 trial with an active drug that couldn't really make it to show overall survival, namely cabozantinib, which is a tyrosine kinase inhibitor. So what do you think about this data, Maria?
Well, this was, of course, a disappointing data, a randomized phase 3 trial that was negative for the first endpoint over survival. So cabozantinib being a MET and VEGF inhibitor, an oral drug showed on the one hand progression-free survival benefit and a benefit for the bone scan activity, so bone scan benefit. But this could not be transferred in an overall survival benefit in this trial. So it was very clearly negative. On the other hand, we also saw some toxicity with the drug. So it was not that well tolerated with 60 milligram, which was the start of dose in that trial. This was also sort of concern. So it is always disappointing to have large scale trials, phase 3 trials that are negative, and a lot of money is sort of wasted for this sort of trials. It's always sad, but that's it. And now I think we won't go on with cabozantinib trials in prostate cancer.
Right. So basically, I mean, I think it's going to be more and more difficult to show overall survival in this disease when we have so many drugs active and postponing death. So do you think, Mark, it's time for personalized medicine for patients with CRPC? I mean, if we would have an ideal biomarker for cabozantinib, active in some patients, toxic in others, or the same, do you think it's now time to change that and to do phase 3 trials only based on biomarkers?
Yeah, so at our Institute of Precision Medicine, we're focusing a trial on patients with advanced cancer, and so we are thinking in terms of trying to identify specific markers where we might be able to identify them as potentially open to other trials. I think the study also is interesting for another reason that we just heard about, is that the drug itself is supposedly a MET and VEGF inhibitor, and we know that it's not really ideally hitting either of those targets. It's not a clean drug, and so there's probably a lot of biology that still needs to be done on that drug, and what were the effective components and what needs to be modified. So in our view, we heard today about precision medicine trial, which we're part of, which is a Stand Up to Cancer trial, and we're going to report this year the results of approximately 150 metastatic biopsies where we've done genome sequencing and also transcriptomics. So I think that's going to be the start of seeing what this type of precision medicine looks like. And I can just say that we're going to see alterations that would suggest patients should be considered for PARP inhibition upfront and other types of therapies that might not be obvious initially. Again, these are patients who have advanced disease. They've already been treated and failed some initial hormonal therapy. So I think it will be something that's very important. Whether we can afford to do this over the long term will be another question, but I think it's an important trial.
Excellent. So this is really the next future. So with this, I would like really to thank the panelists for being with us today. Thank you for following us. Bye-bye.